My patient was a 48-year-old lady who had the background of hypertension and was a smoker. She presented to our hospital following an unprovoked episode of chest pain which woke her up from sleep. She described it as someone had punched her chest. Her troponin was negative, but ECG showed dynamic T-wave changes in the lateral leads. Diagnostic coronary angiography was taken using a standard diagnostic catheters, showed, as you can see, smooth and normal coronary arteries. And this happened next. So the first picture, this one was in apicaudal, and then the second was apicranial when I noted the dissection of the left main and couldn't really figure out how this happened and what was it. So I managed to wire the circumflex first, called for help immediately, obviously, had to change the diagnostic catheter to the guide catheter, asked for colleagues to come and inform the whole team to be alert and orientated. Patient obviously immediately went to the VT, was shocked out of it. I wasn't able to wire the LAD easily, wired the circumflex and just put wire in the LAD vessel. Decided to put the IVUS on the circumflex, which I knew is in the true vessel. And it confirmed there is dissection in the left main. It's a short run. I won't drag it. I allow you to have a look, please. This is circumflex to the left main. And as we come to the left main, the hematoma and the dissection flap is obvious. Then, through the wire which was positioned in the LAD, IVUS run was done, which we can clearly see the dissection flap. And it demonstrates that wire was in the false lumen, not into the true lumen. Wire was still kept in the false lumen, IVUS was still there, and using this information, the true LAD was eventually wired using a BMJ wire. Lesion preparation with the 2.5 semi-compliant balloon and stented with 2 overlapping stents. This is the summary of the procedure that was done. With a 5.0 millimeter non-compliant balloon, the proximal and ostial left main was post-dilated. And this is the final angiography result. Patient went to shock, obviously, but was alert. So it was a pulsed VT, shocked out of it. She was alert and awake and still remembers it. And that's the most painful procedure, part of the procedure that she is still complaining about it. Everything was done so quickly and immediately. Therefore, the LV function remained very well. And IVUS post the stent, which I haven't included, showed well-apposed and well-expanded stent. So now question is here really, what happened actually? What was the cause of this dissection? At the beginning, when I saw that, I couldn't truly figure out what is it. Is it dissection? Is it air? Is it blockage because of the thrombose in the catheter? But it's definite that it was a dissection. So was it just an iatrogenic dissection? A 6 French JL35 diagnostic catheter had dissected the left main, but pressure wasn't dampened. And when we look at the position of the diagnostic catheter in this picture, which is my first picture, it doesn't look bad. Or was it actually a SCAD case? It's difficult and impossible to prove it. But was it a SCAD that there was propagation of the dissection flap to the left main after injection of the contrast, or because in a SCAD situation the wall of the vessel is fragile anyway, the tip of the catheter dissected it? Anyhow, it's not easy to confirm. SCAD diagnosis matches with the presentation symptom of sudden severe chest pain with abnormal ECG findings, although troponin was negative. Distal left main looked a bit hazy on the first diagnostic caudal angiography. And distal LAD, in this view, after the stent, looks a bit hazy and thin, but it's all just putting things together. It's impossible to just diagnose it. So take-home message, as we all know, IVUS is highly recommended for any dissection situation, specifically in SCAD. It helps with the diagnosis and management of this condition, even if there is no complication, even if there is no dissection, helps us with the diagnosis, facilitates the visualization of the lumen, are we in the false lumen or are we in the true lumen? And also it can identify the flap and intimal tear and can demonstrate the hematoma, which we could demonstrate it with our IVUS. And obviously ensures the accurate size of the stent. If there is any acute vessel closure, this is just for the fellows, as all the expert colleagues are well aware of it. If there is dissection, if the wire is in the place, make sure the wire remains in position in the lumen and avoid injecting extra contrast. But what if there is dissection and we don't have a wire in place already, or the wire keeps going to the dissection plane or subintimal? The message here is that keep the wire in the dissection plane, doesn't matter. Keep it there. Use a parallel wire, another wire, to find the true lumen. We can use a microcatheter or do a lumen microcatheter here. Or if the wire keeps advancing in subintimal, we can use a STAR technique, which is a CTO technique, subintimal tracking and re-entry. We can use a special polymer jacketed wire in this situation until the wire eventually goes through the true lumen. Either just based on wire, or we can use stingray balloon, which is out of the subject of this talk. Thank you.